can I share my screen and can we
Yeah,
start, sir?
we can start.
Okay, fine, fine. Once I
Okay,
give a countdown and then we can start.
okay. I think that's fine.
Okay, so it's 3, 2, 1. We are live to the audience. We can start the session. Over to you, Parthasarthi, sir.
Very good evening, one and all. Very good evening, fellow doctors and seniors. As we all know, 1 in 7 out of diabetics all across the world is Indian. And with the burden of disease of this magnanimity, we would also see a proportionate increase in CVD, in CKD, in heart failure, and therapies such so. The international bodies which governed guidelines for diabetes always traditionally had a glucose-centric approach. But somewhere later, somewhere very recently, a few years back, the guidelines said, fine, let's take an organoprotective approach. This was after the landmark study known as the EMPA-REG outcome. SGLT2 inhibitors beyond have shown protective benefits beyond just diabetes, be it cardiovascular, be it renal, ASCVD, so on and so forth. To throw more light on the same, we have today as our eminent speaker for the day, Dr. Mohan Bhargava. Sir is the director and interventional cardiologist at Max Super Speciality Hospital, New Delhi, with over 33 years of experience in cardiology. He has been awarded various prestigious national as well as international fellowships. He has served as ex-senior editorial secretary of the Indian Heart Journal and the ex-president of IMA New Delhi. He is also a member of CSI and has published over 80 articles in national as well as international peer-reviewed journals. On the same note, over to you, sir. It's an honor to have you with us. You can share the slides, sir.
Yeah. Good evening, everyone, all colleagues, and my dear friends. I think I am clear, Dr. Parthasarthi.
Yes, sir. You're clear and the slides are also visible.
So today I'm going to discuss about dapagliflozin, its role of bridging the gap in heart failure management in patients who have diabetes or without diabetes. So when we talk about heart failure is a severe failure of the heart, and it is not in a position to pump enough blood around the body. Symptoms can include breathlessness, fatigue, and swollen limbs. And we know the reality is we have a significant number of heart failures worldwide, which is 26 million. The surprising thing is 37.7 million is the prevalence of undiagnosed cases. And the lifetime risk of developing heart failure is 1 in 5. It's the #1 cause of hospitalization, that is the heart failure. And 50% of the patients who have been hospitalized, they get re-hospitalized within 6 months of being discharged from the hospital. The incidence of heart failure in individuals with or without diabetes in the Framingham study involving more than 5,000 patients and follow-up being for about 20 years, the incidence in diabetes was about 7.6 per 1000, whereas in diabetic women, 11.4. The incidence was more than twice as compared to the non-diabetic, but in females, it was significantly higher. When we talk about the other study, the cardiovascular health study, involving more than around 6,000 patients, where the follow-up was for 5.5 years. The diabetes incidence was the heart failure incidence in diabetes was 44.6 per 1,000, and in women it was 32.5 per 1,000, which was significantly higher as compared to the non-diabetic. In the heart and soul study involving 839 patients, the follow-up being 4.1 years, the diabetes, the incidence of heart failure was 36.6 per 1,000, whereas in diabetes it was almost half. So double the incidence in patients with diabetes. In the enhanced study involving more than 13,643 patients, follow-up being for 19 years, in diabetes, the incidence of heart failure was 65.5%, whereas in women it was 61.8%. Whereas in the non-diabetic, it was 37 and 29% respectively. The kidney disease is very significantly involved in patients who have hypertension, diabetes, and the kidney disease facts. The fast facts are 850 million population worldwide have kidney disease, and 2.4 million deaths occur each year. The diabetes and hypertension contribute to about 75% of, and it is the most common cause, primary cause for CKD. And surprisingly, 9 in 10 people who have CKD don't know that they really have kidney disease. Prevalence and manifestations of kidney disease in diabetes and non-diabetic population, all forms of kidney disease, whether it is albuminuria and the other involvement, it is significantly higher in patients who have diabetes as compared to non-diabetic. In the enhanced studies, the prevalence of diabetes, like the CKD, was 43%, whereas in non-diabetic, it was 9.4%. And in these patients, the 10-year cumulative all-cause mortality is significantly higher at 19.10% as compared to 8.6 in people who do not have diabetes. So diabetes and heart failure are linked, and treatment should also, so that both are taken care of. People who have type 2 diabetes characterized by elevated sugar levels have 2 to 4-fold increased risk for heart failure than patients who do not have diabetes. But heart failure, and it is unable to pump oxygenated blood throughout the body, and also is a risk for diabetes, and are characterized by insulin resistance and high levels of inflammation. The 6-year CHF incidence per 1,000 person by the age group, in less than 45 years, it is 4.5 compared to just 0.4% in the non-diabetic. And it increases once we reach more than 65, where the level is 38.7% as compared to 13.7%, whereas 75 to 84 years, it is high at 63.9% as compared to 34.7% per 1,000 population. Diabetes, heart failure, and renal dysfunction. The vicious circle, you can see diabetes, it's a major risk factors. It defines the intensity of heart failure, and it causes significant amount of kidney disease, which leads to sodium retention and the occurrence of heart failure. The In diabetes, like we have the pancreatic insufficiency, decreased insulin secretion, hyperglycemia, presence of macroangiopathy leading to myocardial infarction, decreased cancer handling, myocyte necrosis, LV dilatation, and thereby heart failure with reduced ejection fraction. The ages leads to fibrosis, inflammation, which leads to endothelial dysfunction, microangiopathy, and the fibrosis lead to, because of the sarcomere stiffness, LV restriction occurs, leading to heart failure with preserved ejection fraction. In heart failure, we have the RAS system gets activated, the sympathetic system gets activated, lipolysis occurs, lipogenesis, gluconeogenesis, obesity also contributes to insulin resistance. The pathophysiology of diabetes and heart failure. Diabetes leads to hyperglycemia, the insulin resistance, the hyperinsulinemia. There is autonomic dysfunction. The calcium handling gets increased. There's increased fatty acid utilization, formation of AGs, leads to fibrosis, RAS activation, which leads to cardiomyocyte hypertrophy, LVH. In addition, there is inflammation, dyslipidemia, endothelial dysfunction, increased incidence of coronary artery disease leading to ischemic cardiomyopathy and the diabetic cardiomyopathy, which is the cause for heart failure in diabetes. The therapies which are available for diabetes, the biguanides, the sulfonylurea, the thiazolidine, the GLP-1RA, DPP-4 inhibitor, the SGLT2, the insulin, and they act on various sites to provide benefit for diabetes. And diabetes, like there's significant incidence of heart failure. The biguanides have a variable response, which is seen like in different subset of patients. And the potential pathways that could be targeted is altered myocardial substrate, the myocardial signals, the oxidative stress signals, the lipotoxicity, the inflammation, the AR stress, the insulin signal, the B2 adrenergic receptor signaling, JRK2 signaling, the renin angiotensin aldosterone signaling, and autophagy and the ages. The current available therapies, we have the insulin and the sulfonylurea, the impaired insulin secretion, and DPP-4 inhibitor, the GLP-1RA cause increased glucagon secretion. Metformin, that increases the HPG, and the decreased incretin effect like DPP-4 inhibitor, these all act on decreasing the hyperglycemia. The SGLT2 mainly cause increase it causes increased glucose absorption leading to glycosuria, whereas the thiazolidine, they cause decrease in glucose uptake. The effects of diabetes mellitus treatment on risk of heart failure. If we talk about the insulin sulfonylurea, there is no definite CV outcome trials examining the role of sulfonylurea in heart failure that have been conducted. So there are some studies where they have shown the events do not increase with sulfonylurea, mainly the glimepiride. We talk about GLP-1RA, there is no increased risk in heart failure or hospitalization for heart failure. Modest improvement in ejection fraction in heart failure patients. The metformin, it decreases the mortality in heart failure patients. and also reduces cardiac hypertrophy. Whereas if we talk about SGLT2, it increases the glucose reabsorption. Thiazolidinedione causes decreased glucose uptake, but it leads to fluid retention and weight gain, and that's why it prevents its use mainly in patients who are class 3 to class 4 symptomatic. And DPP4 leads to increased lipolysis. So the guideline recommendation for oral anti-diabetic, if patients have ASCVD, in those patients, SGLT2 and the GLP-1RA are used. Whereas if CKD is present, mainly those patients, the SGLT2 are used. And if one has to achieve in minimizing the weight gain or promote weight loss, the GLP-1RA, SGLT2 are preferred. This is by ADA 2020 recommendation. The 19 update with ADA and ESSD, if ASVD prominent, then the GLP-1RA and the SGLT2, as I mentioned earlier, if heart failure or CKD predominates, then in those patients, SGLT2 are preferred. If the goal is not achieved, then the other drugs can be added to. The impact of glucose-lowering medications on cardiovascular endpoints in cardiovascular outcome trials and heart failure hospitalization from the AHA 2019. The various trials which were for GLP-1 agonist, the lixisenatide, the Alexa trial, which was in 2015 in patients with ACS involving more than 6,000 patients. And in this, there was no difference in the risk. In the leader trial for liraglutide, which was also used for high risk or CVD patients involving more than 9,000 patients, and 14% of these patients had heart failure. The follow-up being for 8.3. Here also there was no difference in the risk, mainly the impact on heart failure hospitalization. Similarly, semaglutide sustained 6 trial in 2017, which was also done for CVD and high-risk patients involving more than 3,000 patients, follow-up being for 2.1 year. Here also no difference in risk. Similarly with exenatide in the Excel study was seen. However, in DPP4 inhibitor with sexagliptin, the SAVOR trial, CME 53, it was seen this was study involving 16,492 patients. Here there was increased risk of heart failure, which was seen. The algogliptin in the examined study, however, showed no difference in risk. Similarly, sitagliptin in the PECOS trial in 2016 showed no difference in risk for hospitalization due to heart failure. And in SGLT2 inhibitors, then we had the landmark trials giving fantastic results. And in this, the EMPA-REG outcome in 2015, these patients were more than 7,000, follow-up being for 3.1 year, and the risk was significantly decreased, with the hazard ratio being 0.65. Similarly, in the CANVAS program with canagliflozin, in high-risk cardiovascular risk patients, the patient number being more than 10,000, 10,142 patients, median follow-up being for 3.6 years, the cardiovascular death, MI, stroke, that was for the primary outcome, and impact on heart failure hospitalization was significantly reduced, with hazard ratio being 0.67. So the association of glycemic medications with the risk of cardiovascular events and heart failure hospitalization, if you see the EMPA and the canagliflozin in EMPA-REG and CANVAS showed significant benefit in as far as reduction of major cardiac events as well as heart failure hospitalization was concerned. And then we had the clinical consideration for SGLT2, which was recommended by ADA, ESAD, as well as AHA. And for patients with or without established atherosclerotic cardiovascular disease with HFrEF, ejection fraction being less than 45, eGFR 30 to 60, and UACR more than 30, but particularly UACR being more than 300, the level of evidence for benefit was greatest for SGLT2 inhibitors. The SGLT2 inhibitors are also recommended in patients with type 2 diabetes with heart failure, particularly those with HFrEF, to reduce hospitalization secondary to heart failure, MACE, as well as cardiovascular mortality. The SGLT2 inhibitors are recommended to prevent the progression of CKD, heart failure, hospitalization, MACE, and CV death in patients who have diabetes with CKD. And SGLT2 inhibitors are first class of glucose-lowering drugs to reduce heart failure hospitalization, whether patients have diabetes or non-diabetic, combined with significant reduction in cardiovascular events and mortality, which was seen with SGLT2, it is reasonable to consider SGLT2 as a part of preventive strategy in those patients who have diabetes and have high risk for heart failure. There are also glucose lowering medicine choice in patients who have established heart failure and diabetes. This class appears promising for treatment of established heart failure in patients without diabetes mellitus. So the bridging the missing link between the cardiorenal syndrome with or without diabetes. The unmet needs in the management of heart failure and cardiorenal syndrome, it is seen in patients with HFrEF. The proportion of patients receiving guideline recommended doses of ACE inhibitors and beta blockers is as low as 22 and 12% respectively, whereas in HFrEF patients, the treatment is reliant on management of comorbidities and symptoms. Cardiorenal syndrome and the RAS inhibitors and diuretics can be beneficial, but they can also worsen renal function. So the caution has to be there. And the cardiorenal efficiency of newer anti-hyperglycemic drugs in primary and secondary prevention. In primary prevention, patients who have diabetes with multiple risk factors, the SGLT2 causes decrease in heart failure as well as diabetic ketoacidosis, whereas GLP-1RA and DPP-4 inhibitor, they have an equivocal response. In the secondary prevention, the MACE, heart failure, and diabetic ketoacidosis are significantly reduced by SGLT2 inhibitor, whereas the GLP-1RA shows reduction in MACE events. The patient example cases, like here are some examples where, the first example is a 68-year-old woman who's at high risk for heart failure and diabetes, hypertension, hyperlipidemia, coronary artery disease, creatinine being 1.1, and eGFR 55. The best option treatment is metformin and SGLT2, mainly to decrease the risk of cardiovascular events and heart failure hospitalization. And GLP-1 receptor antagonists may decrease the risk for cardiovascular events. If these patients, the goal is not achieved, then the other drugs may be added to get into the target control. Second case, 78-year-old man with diabetes mellitus, recently diagnosed case of HFrEF stage C caused by non-ischemic cardiomyopathy, ejection fraction being 30%, creatinine 1, eGFR 77. Here, patients should be treated with metformin and a SGLT2, which may decrease the risk of heart failure hospitalization. The thiazolidine are contraindicated because they can increase the failure. Avoid DPP-4 inhibitor, mainly if there is recent history of heart failure. And if one has to use, one can use sitagliptin because they do not tend to increase the incidence of heart failure. Avoid GLP-1 receptor antagonists if there is a recent heart failure. Sulfonylureas and insulin can be added. Case 3, 59-year-old man with diabetes and recently diagnosed C, stage C, heart failure with reverse ejection fraction being 60%, creatinine 1.1, GFR of 71, metformin and SGLT2 may decrease the risk for heart failure hospitalization. Thiazolidine are contraindicated. Avoid DPP-4 inhibitors and the like if one has to use, one can use sitagliptin may be added. In case 4, 72-year-old woman with diabetes mellitus, stage C, heart failure with reduced ejection fraction caused by ischemic cardiomyopathy, ejection fraction 35%, creatinine 2, eGFR of 25. Here, insulin should be given. Thiazolidine are contraindicated. Metformin should be avoided once GFR is less than 30. The trials of SGLT2 inhibitors at eGFR as low as 20 ml are ongoing, but for now, one should avoid. And according to ADA and ESSD, the first oral anti-diabetic class to reduce CV mortality and heart failure risk, the only class with cardiorenal benefits with or without diabetes, and even it reduces the event rate. SGLT2 inhibitors bridging the gap in heart failure management in patients who have diabetes or without diabetes. The kidney and glucose hemostasis in the kidney is involved in the regulation of glucose by 3 different mechanisms. The release of glucose in the circulation, uptake of glucose would occur, reabsorption of glucose into the circulation from glomerular filtrate to conserve glucose. It is seen that once SGLT2 is used, the almost the 179 grams out of the filtered glucose, which is 180 grams, would occur, and thereby glycosuria would occur. The SGLT2 inhibitors and glucose management, it affects multiple sites in the diabetic kidney, a novel insulin-independent mechanism of reducing renal tubular glucose reabsorption, thereby producing a reduction in blood glucose without stimulating insulin release. And it enhances the natriuresis, causes contraction of the intravascular volumes, alters the intrarenal hemodynamics, and contributes to the beneficial effects in reducing the blood pressure, the body weight, and decreasing the albuminuria. These pleiotropic effects have been translated into reduction of cardiovascular events and the preservation of kidney function in larger cardiovascular outcome trials. And it decreases uric acid too. And it is seen if the SGLT2 inhibitors are introduced early, they can even prevent the albuminuria as well as the drop in hemoglobin, plus retain the erythropoietin levels for a longer time and prevent the hemoglobin from dropping. That would be seen if the SGLT2 are introduced early. The SGLT2 inhibitors cardio and nephroprotection. It reduces the after and preload. It increases the cardiac, uh, like decreases the fibrosis, increases the cardiac myocardial function. It increases the systolic as well as diastolic function, reduces the MACE as well as reduces the heart failure hospitalization. Whereas renal protection occurs secondary to by its action on decrease in intraglomerular pressure, the blood pressure, and it prevents the progression to CKD. The cardio and nephroprotection, it decreases the glucotoxicity, decreases the plasma volume. As a result, it increases hematocrit, increases the hemoglobin, decreases the systolic blood pressure, decreases the arterial stiffness, improved cardiac fluid energetics. It increases the weight loss, decreases the adiposity, decreases inflammation, thereby providing significant cardiac and renal protection. The SGLT2 inhibitors, beyond glycemic control, it is seen that recent results in non-diabetic experimental CKD models, it is seen besides the uh, like its renal protection, cardiorenal protection, it has a different mechanism by which it can possibly do direct renal protection, which is the decrease in oxidative stress, the fibrosis induction, the decrease in local inflammation, the decrease in tubular senescence, and decrease in glomerular damage. The mechanistic rationale for investigating these inhibitors in heart failure beyond type 2 diabetes, the rationale is that diabetes and heart failure have similar pathological features. They have endothelial dysfunction and insulin resistance. The mechanical effects of SGLT2 inhibitors are seen in patients with or without diabetes. The CV2, the cardiovascular benefits of these drugs are largely independent on glucose level, and diuretic effects, the metabolic effects, diuretic effects would be mainly glycosuria, natriuresis. The metabolic effects would be increased glucagon and increased ketone bodies. But all SGLT inhibitors are not same. The journey of dapagliflozin has gone beyond glycemic control, and it starts from 1835 when French scientists isolated fluorescein and apple tree bark. Then the trials regarding the outcomes, cardiovascular outcomes in 2008, the FDA approval of first SGLT2 for diabetes, the EMPA-REG outcome trial of empagliflozin was in 2015, the CANVAS in 2017, and 18 we had to declare TB58 followed by DAPA-HF trial. And comparison of the CV indications for SGLT2 for patients with type 2 diabetes, it is seen for primary prevention. We have dapagliflozin, which like is the only drug which is being tried and the data is available in primary prevention. In the secondary prevention established CVD disease patients, dapagliflozin trials are available with DAPA, CANA, and empagliflozin. Dapagliflozin is the only SGLT2 with a cardiovascular outcome and with the majority primary prevention patient population declared trial with dapagliflozin had more than 17,160 patients, and it is the first and only FDA approved SGLT2 for patients with HFrEF with or without diabetes. And no other SGLT2 indication to reduce CV death in patients with HFrEF with or without diabetes. So dapagliflozin offers a novel pathway that compensates current therapies for heart failure with reduced ejection fraction. And we know the important action is the downregulation of sympathetic activity, the significant reduction in preload and afterload, and improved survival in patients with FRF. So the approved indication and dose details in type 2 diabetes as an adjuvant to diet and exercise to improve glycemic control in patients with type 2 diabetes, the to reduce the risk of hospitalization for heart failure in adults with type 2 diabetes and establish cardiovascular disease or multiple risk factors in heart failure indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in patients who have reduced ejection fraction and are class 2 to 4 symptomatic. Dosage and administration in type 2 diabetes, the recommended dosage is 5 milligram orally once daily to be taken in the morning with or without food. In patients who tolerate dapagliflozin, it should be increased to 10 milligram once daily to reduce the risk of hospitalization for heart failure in patients with type 2 diabetes and establish CV or multiple risk factors. The recommended dose is 10 milligram once daily. In heart failure, it is 10 milligram once daily. Regarding the cardiorenal efficiency, dapagliflozin is neutral for the MACE events and the heart failure hospitalization and the diabetic ketoacidosis is significantly reduced. Dapagliflozin in patients with heart failure and reduced ejection fraction, the DAPA HF trial, and in this, it is evaluated in patients who had reduced ejection fraction. There were two arms, and the placebo and the dapagliflozin arm involving more than 2,370 patients, and the follow-up was done for 18.12 months. And the primary endpoint was worsening of heart failure, hospitalization, or an urgent visit resulting in intravenous therapy for heart failure or cardiovascular death. The primary outcome, the hospitalization for heart failure, the death from cardiovascular causes, and death from any cause, they were significantly less in the DAPA arm as compared to the placebo. Then came the DAPA CKD trial, in which the dapagliflozin was compared with placebo, and the risk for renal and cardiovascular events in patients with CKD without diabetes were studied. And in this, it was double-blinded placebo-controlled trial. Dapagliflozin 10 milligram was used, and in the other arm, the number of patients were 2,152 in each arm, follow-up being for 2.4 years. The primary endpoint was composite outcome of sustained more than 50% decline in eGFR, the end-stage kidney disease, or renal or cardiovascular death. Whereas the secondary outcome, composite outcome of sustained more than 50% reduction in eGFR, the end-stage kidney disease or renal death, or cardiovascular death or hospitalization for heart failure, and all-cause mortality. In this, the primary composite endpoint, the renal impairment, the composite death from cardiovascular causes or hospitalization for heart failure, death from any cause was significantly lower in dapagliflozin as compared to placebo. Then the albuminuria lowering effect of DAPA alone or in combination with saxagliptin and the effect of the combination on glycemic control in patients with type 2 diabetes and CKD. This was the DELIGHT trial, and in this, the placebo group was compared with DAPA group as well as the combination group, and at 24 weeks, At follow-up, the results were seen that DAPA showed, compared to placebo, showed significant improvement, as well as the combination showed even further improvement in patients who had moderate to chronic CKD. Dapagliflozin versus placebo in patients with type 2 diabetes and moderate renal impairment, the DRIVE trial. In this, the adjusted mean change from baseline, 95% CI during 24-week period, and these patients were followed for 3 weeks. They showed significant benefit in the DAPA arm as compared to placebo. Then the RED trial, which was the renoprotective effects of dapagliflozin in type 2 diabetes. In this, the phase 4 monocenter randomized double-blinded compared controlled parallel group intervention trial, and it was seen that SGLT2 showed significant benefit in patients who had hyperglycemia. The clinical trials expand the population that benefit from these SGLT2 inhibition. The EMPEROR reduced and the DAPA CKD, where patients with type 2 diabetes, the SGLT2 improved glycemic control, and patients even without diabetes, benefits were seen beyond glycemic control. And now heart failure, like the ejection fraction less than 40 and eGFR even less than 20, or eGFR more than 25 and albuminuria more than 200 milligrams, the EMPEROR reduced as well as the DAPA CKD clinical trial showed that SGLT2 inhibitors reduce hospitalization secondary to heart failure and the occurrence of heart kidney endpoints in patients either who had diabetes or who were without diabetes, demonstrating significant organ protection, which is due to factors beyond glucose lowering. Therefore, comorbidity inherent in the cardiorenal syndrome is alleviated with the use of SGLT2 inhibitors. So the future appears to be more brighter. Dapagliflozin does what really we need an ideal drug to do, like it improves the symptoms, it improves the survival, and in addition, it reduces the hospital admission. Presently, more than 80 trials are ongoing beyond glycemic control, DAPA in PEFREF, DAPA in heart failure readmission, DAPA and effect of cardiovascular events in acute heart failure, thrombolysis in acute myocardial, that is DAPA ACT, heart failure TIMI 68, head-to-head comparison of EMPA and DAPA, the night blood pressure control in diabetes, then HFrEF, HFpEF, the DAPA in diabetic patients with decompensated heart failure, efficacy and safety of DAPA in acute heart failure patients, patients of respiratory failure post-COVID, DAPA, the effect on symptoms and biomarkers in patients with heart failure, dapagliflozin on hypertensive heart failure patients after sacubitril valsartan therapy, and many more. So the DAPA is the drug which bridges the gap which was required to provide significant benefit in patients who have diabetes, non-diabetes, who have heart failure, as well as the protection of kidney. The SGLT2 class recommended by the ADA, ESLT, the ACC in the management of type 2 diabetes with ASCVD, heart failure or CKD for reducing hypoglycemia and weight gain. More than 350 trials are completed and 80 are ongoing. And landmark COT trial, the DAPA, heart failure and the CKD trial have shown survival benefits as well as significant reduction in hospitalization secondary to heart failure as well as the event rate. The DAPA is the first and only drug approved by SGLT2 for patients with HFrEF with or without diabetes. No other SGLT2 have shown to reduce cardiovascular death in these patients with or without diabetes. The future is bright. It's the molecule bridging the gap of heart failure, CKD, and hyperglycemia. Thanks for patient listening.
Thank you very much, sir, for your for such a wonderfully taken presentation. Very clinical. Uh, uh, Instead of being, purely didactic, there were a lot of clinical takeaways from the way you took the session. So until our audience comes back to us with certain questions, so the ESC guidelines, just from your perspective as a cardiologist, ESC 2021 placed SGLT2 inhibitors as one of the drugs which gives mortality benefits, one of the four pillars, along with an RNA/AC inhibitor, an MRA, and a beta blocker. So how does this data change your practice? How does this guideline change your practice?
Yeah, actually, any patient where you find that patient has a risk for heart failure. So if you have a subclinical pickup of any data, whether it is the your echo pickup or the GS training is there, GLS training, you pick up subclinical say dysfunction. I think these are the patients who would benefit maximum because uh, like if they are put on drugs, obviously they'll not go into heart failure. Second, even patients who have heart failure, they would also benefit because the mechanisms are such that the it provides the protective role on the heart by reducing the load, preload, the afterload, then significant role in even in remodeling, and even as far as renal protection is concerned, significant renal protection is there. So one would like to introduce the drug early because then the protection in patients who are they're going to go into heart failure, they would have maximum benefit. Similarly, patients who are going to who have albuminuria picked up early, they would the albuminuria would get corrected. They would not go into renal failure, or it would be significantly delayed. We have to see how long the benefit lasts. Possibly, if patients are treated early, they may remain stable. The renal parameters may stay all for a more length of time. The parameters may stay all right. We have seen that patients. There are some patients who have a hemoglobin drop, but all the investigations are all right. But when you introduce patients who have been put on these drugs, they have a hemoglobin buildup. And I showed you the mechanism because the plasma volume contraction occurs, the hematocrit would rise, the hemoglobin would rise, and obviously the albuminuria is prevented. So the hemoglobin can rise in these patients once they get treatment early.
So the results of the DELIVER trial, that is dapagliflozin, which would majorly deal with HFpEF patients, the top line results were just out. So probably it follows the same promising pattern as empagliflozin had shown with the emperor preserved outcome studies which were published earlier. Of course, the DELIVER results have yet to be published. Only the top line results were out day before yesterday. What about this subset of patients, sir? What is your key message to practicing clinicians on HFpEF and how HFpEF should be detected or when should it be suspected?
See, basically, that's why the indications are patients who have high risk for failure, or patients who have failure, or patients, because those are the patients who are going to benefit. because then you'll have statistical significance will be showing that the p-value is significant. Because if you use thinking that these patients can go into failure, then obviously the p-value you would not get any reduction because
Significant.
they already have they are low risk patients. There you cannot document the benefit of these drugs. But obviously, if introduced early, even uh, the delay in target organ damage may be seen. That would be the another subset of patients where that would be the another the other groups. You can have two groups where you introduce early and then see how the end organ uh, the target organs how they behave. So that would be another type of prevention study which one could do, and possibly this drug may still be beneficial because
Okay.
it has a very wide range of mechanism providing significant benefit. That too, it's two type of benefits are there on the heart as well as the renal, and obviously even the hyperglycemia, where we have
Sure.
not discussed about the other benefits of hyperglycemia, which would be like the diabetes itself causes.
Sure.
So
Point very well taken, sir. Sir, purely from a clinical practice perspective, in your diabetic patients, has euglycemic ketoacidosis ever been a concern? If so, what are the subset of patients you might wish to avoid uh, dapagliflozin purely from your clinical practice?
euglycemic.
Euglycemic ketoacidosis. Yes, sir. So this was an entity which only came when SGLT2 inhibitors were out uh, in the market saying, oh, probably the person is excreting his sugars out, but still showing evidence of ketoacidosis because of the shift towards ketonemia and ketone bodies. And another endocrinologist opined very well on this note in a positive direction, saying possibly insulinopenic patients, patients who are catabolic, patients who are thinned out, uh, uh, these subset of patients who require insulin and possibly because of not choosing patients, maybe an SGLT2 inhibitor is given, possibly these patients
Yeah,
land up. But is it so? Does it mirror with clinical practice
it
or
yeah possibly there is because it increases the glucagon level.
sure?
There's a possibility that these patients can be helped, but obviously one has to see in more number of patients where we can provide benefit to these patients.
Sure. Thank you very much, sir. Thank you very much for your time. With your permission, sir, we would like to close the session.
Yeah, thank you. Thank you
Sir,
very much.
just I would like to give the vote of thanks. It was an honor to have you with us today, and we are very sure that uh, the entire audience who would have heard your session would have definitely benefited from the clinical takeaways as discussed by you and implement in their personal clinical practice. Dear audience, we also take our time to thank you for attending this valuable session and improving your knowledge and getting takeaways for your clinical practice. Last but not the least, we also thank Imagica Health, our technology partners, for the smooth streaming of this webinar. Thank you, one and all. Good night.
Thank you very much.
Thank you, sir.
Thank you.
So with your permission, shall I end this meeting, sir?
Yeah.
Yes, please, Himanshu.
Yeah, thank you very much. Thank you. So from here, I'm ending this meeting. Thank you.
Sure.